Hi, good evening, everybody. We're at past, so we're going to get going. Welcome to our September Open Hand Therapy webinar. We're so excited that we're in spring here in South Africa and it's warming up. I feel like we've dived into summer very quickly. This webinar is brought to you in association with the University of the Witwatersrand and the South African Society for Hand Therapists. This evening's topic is complex hand injuries, what to do when everything is hurt, by Trish Griffiths. Thank you so much for being here with us. Here's our contact details on the slide. Please feel free to contact us with any questions. But for now, it's time to start our webinar. So I'm just going to stop sharing my screen and introduce our speaker for this evening. So Trish graduated as an occupational therapist in 2003 from Stellenbosch. In 2009, she obtained her advanced specialist in hand therapy. She's a practice owner of the Hand Rehabilitation Unit in Cape Town since 2011. She works closely with orthopedic surgeons, providing comprehensive patient care. She previously worked at the very busy unit in Groote Hospital, and she continues to volunteer there on a weekly basis. She also gained experience working at a number of hospitals in London and has presented numerous courses over the past 10 years. So we're really excited to have you share your knowledge with us this evening, Trish. You're welcome to share your screen and go ahead when you're ready.
Hi, everybody. It's really amazing to be here. Thank you so much for the invite. I think it's such an exciting initiative, and I'm really excited to be part of it. So I'm going to be talking about the really complex hand injuries when everything seems to be damaged and you don't quite know what to do. And we're going to go through some case studies, and I'm going to talk you through what we did and what worked, maybe what didn't, and hopefully we'll learn something along the way. Okay, so I work at a really large level 1 trauma hospital right in the city centre on the foreshore of Cape Town. So I see a lot of workmen's compensation cases. I see the guys with the nasty injuries from the construction sites. I see the guys with the blade injuries while they're out at sea, where they need to chop the fish heads off, the machinists, and all of those. And because it's a level 1 trauma hospital, these get flown in from all over the country. And I have a huge advantage of working together with hand surgeons. And so I'm just going to choose a few of those cases, and we're going to work through them. Just to quickly go over some learning outcomes that I'm hoping you guys will become familiar with by the end of this. So we're going to talk quite a bit about tissue healing timeframes and when you can start moving things. And then the concept of functional anatomy, because it's so super important when you are needing to immobilize a hand, knowing what position to immobilize in. And then just a few useful, quicker assessments that I use to monitor progress, because I think it might be useful for you. So there's not always time to measure every single joint range of motion. And then just have an idea of how to prioritize your problem list and how to progress your therapy as your patient rehab progresses. And then just a little disclaimer, this presentation is aimed at the novice and the beginner hand therapist, but perhaps the more experienced can assist with the discussion at the end. So the agenda, we're going to look at the basic hierarchy of tissue protection and tissue healing timeframes, functional anatomy, quick assessments, and then we're going to delve into the case studies, and then we can just have discussions at the end. So hand surgeons will always prioritize in this order. First of all, blood supply. If there's no blood supply, the limb will die. Second of all, skeletal. You need to have the support structure. Then you have your nerves, your flexor, your extensors, your ligaments, and lastly, skin closure, so that you prevent infections. Now, there are quite a few exceptions to this rule, and it often depends on the severity of the injury. But I just want to highlight that if there's a crush component with a mechanism of injury, you're going to have heightened swelling, so much more scar tissue, higher pain levels. Basically, your inflammatory phase lasts a little bit longer. And these are the trickier patients. And a lot of these big traumatic cases seem to be crush injuries. Ideally, you have a planned approach with your hand surgeon so that you have realistic expectations. And an example of this is your surgeon may repair a high ulnar nerve, and we know that it's realistic that they may get protective sensation back, but not necessarily motor function. So you need to work around that, and you need to explain this to your patients. And then always think about functional outcomes as your goals so that they are realistic and they're understandable for your patients. This is just a video showing how closely I get to work with my hand surgeon. I'm so super lucky. This is one of the cases we're going to see later on in the case series. Okay, so just to mention the phases of healing, because this is very important when you're deciding when you can start to move things, what you're wanting to move, how much and how aggressively you're going to start moving. And that's to bear in mind that the inflammatory stage lasts for about 5 days, I normally say. I don't like to treat patients maybe before the 5 days, actually, depending on how swollen they are. But if they are incredibly swollen, then obviously we want to get involved very, very early to help them reduce the swelling. And then your fibroplasia phase, which was 5 days to 36 days, and then your remodeling phase. And you've got quite different approaches in each of these healing phases. And I will take you through the different tissues as we go. The following slide, apologies, is a bit blurry. I'm not going to go into huge depths, but it's just in case you wanted to know what was happening on a cellular level. But I think it just gets a little bit too complicated. Okay, so I have been told that a tendon takes 100 days to heal. And so initially, we want to be incredibly careful. I am just going to give you an example of how my protocol that I use in my head and how I like to guide my patients. So for the first 4 weeks, I tell my patients they can move within the splint safely, as I show them. They can move, but they cannot use their hand. And then only from 4 weeks do I allow them full active range of motion out of the splint. And then you would give your patients the traditional tendon gliding exercises, wrist tenodesis, anything to help the soft tissue move. I allow light functional use of the hand from about 4 weeks, discharge the splint from 6 weeks. I would start stretching out a repaired tendon with the surgeon's permission from around 6 weeks. But, and I'll give you an example, I would do the stretch only with the rest of the tendon detensioned. And what I mean by this is if we're talking about flexor tendons and your patient is developing a fixed flexion deformity at the PIP joint, I would start to stretch out the PIP joint into extension, but I would do it with the wrist in maximum flexion and with the MCP joint flexed so that I have detensioned that tendon. And then I would also start strengthening again with the surgeon's permission around 8 to 10 weeks. When in doubt, you chat to the surgeon. They know how strong their repair was. Nerve healing depends on the surgeon's preferences, but you usually only protect for about 2 weeks. Digital nerves you may not protect at all unless the level of injury is around the MCP joint. And so you can start light function quite a bit sooner out of the splint from about 2 weeks. And then you're going to go on to think about your functional splinting. So we know with radial nerves, the problem is the wrist and the fingers can't extend. So you're going to assist with that. The ulnar nerve is the lack of intrinsic. So the patients develop a claw hand. So you're going to splint to prevent that. And then the median nerve, obviously, you're going to splint to allow for thumb opposition. In terms of fracture healing, again, it really depends on the severity of the fracture, of the gap. The larger gap will take longer to heal, but you need to think that if the fracture is intra-articular, that you need to start moving the joint as early as possible. Generally, we'll only protect a fracture in a splint for about 4 weeks. If they're pain-free, you might start moving earlier. But then do bear in mind that your middle phalanx, mid-shaft, takes the longest to heal. And so you might want to just think about protecting those ones for a little bit longer. And then, of course, ligament healing. It takes probably a good 6 to 8 weeks sometimes. And this is because of the poor blood supply to those little ligament fibers. But you're always going to try and allow for safe movement to prevent stiffness from the beginning. And then, just in case you didn't know, smoking severely delays healing. And it's so important that you educate your patients on this. So obviously, the cells that are healing need a lot of oxygen as part of the process on a cellular level. And your organs and your brain are going to take oxygen first. So by the time the blood reaches the hands, the feet, there's not much oxygen left for the healing process. So 1 cigarette causes 4 hours of insufficient healing in the hands and feet, 2 cigarettes, 8 hours, 3 cigarettes, 12 hours, and so on and so forth. So it's really important that we also educate our patients on that. Okay, so the concept of functional anatomy is so important if you're going to be splinting or immobilizing the hand in any way. You need to understand how the fingers move. You need to know that when the fourth and fifth fingers bend, the metacarpals are so much more mobile and there's an arch that is formed. And the splint needs to allow that if your fingers need to move within the splint. You need to know that your distal palmar crease is curved. It's not a straight line. So when those back slabs are put on, they need to be below the distal palmar crease. And remember, the little finger, the crease is even lower. So look out for those. And it's the same with the thenar crease. It's telling us how much movement happens and where the movement happens. So you need to be aware of the shape of the hand and where and how to splint around those. Again, the arches of the hand are so important for function. And if you're going to flatten the hand in a really tight plaster of Paris, for example, you may be squashing nerve endings and causing pressure sores. And then, of course, understanding the balance between our flexors and extensor length. So you can get that tenodesis effect. So there, a picture on the left is just showing how if we individually flex our fingers, they actually point directly to the scaphoid bone on the radial side of the wrist. And that is so, so important if we are trying to chase finger flexion or MCP joint flexion, that we're pulling the fingers down into flexion, sort of in the correct angle. When we flex all our fingers together, they do straighten each other out a little bit, but they all are facing towards the radial side. So you need to pull the fingers down towards the radial side and not the little finger down straight. And then the pictures on the right-hand side just showing the curves of the hand and how important they are for function and grasping. So when we make splints, and the thermoplastic splints are ideal because we can remold them and change them and shape them if we didn't get it right the first time. But what I'm showing you with the gray circumferential wrist splint and that line across is that it is below the distal palmar crease, so you can get full MCP joint flexion, which is so important for regaining a full fist. And if you are blocking that MCP joint at all and your patients cannot flex their fingers, there will be extrinsic tightness and they will struggle to get all the way from there down to there and regain a fist. And that's going to be then your priority when you're trying to rehab them. And then the splint on the right-hand side is exactly the same as the gray one. You're just looking down on it. And that's just showing you how we can preserve the arches of the hand, prevent compression sores and nerve compressions. The position of safe immobilization. Guys, this is a very important concept in hand therapy. From here, if you do have to immobilize absolutely everything, then this is the position you want to aim for. It is much easier to get your fingers back into flexion when your MCP joints are there. And your thumb, if you're going to immobilize the thumb, it needs to be in the right position because it's impossible to function with your thumb sitting next to your hand in extension. So the ideal position is wrist in 30 degrees of extension, your MCPJs in 70 to 90 degrees of flexion, your IPJs in full extension, and your thumb in opposition. So even if that thumb gets stiff, it can be a post against which your fingers can oppose, and that means function, picking things up. So the quick assessments that I always try to use, just so that I can measure progress at each session, are always the pain scale. I'm always looking to try and reduce pain predominantly. The tip to the distal palmar crease measurement, and I'm going to show you a picture of that later. Measuring the web space, I'm going to show you a picture of that as well. And then the picture there just shows the Kapanji opposition measurements. I always tell my patients, look, this is not functional. As long as we get you to the middle finger, index finger, middle finger, you are able to start doing function. This is just a measuring tool. And obviously you go for gold. You go for as much as you can. And then swelling is one that I prioritize. I use a little measuring tape and I will measure around the PIP joint or mid P1. I just document where and what I'm measuring so that each time I can remeasure and make sure that the swelling is coming down. And then the figure of 8 is the one that goes around the whole hand if the whole hand has global edema. And then the manual muscle testing, there's a nerve injury. It's always good to just double check, is there a flicker, is there a movement? Because as you start getting muscle activation or muscle reinnervation, then you want to start moving those muscles and getting them working and strengthening them as quickly as possible. So this is how you can do a really quick measurement from the distal palmar crease up to the fingertip. And it's a nice quick way. Either you just do the middle finger or index finger, whatever, or you can do all 4 fingers, but just to keep making sure you're getting those fingers closer to the palm. I've shown you both, but I personally actually only use the picture on the right-hand side because having your thumb in opposition again is functional. The one where it's straight down is not necessarily functional. It's just a way of measuring web space. So that's how I like to measure my web space. I always tell my patients to stretch as though they're going to grab their mug of coffee. And that's how I describe it. Okay, now we're going to get to the case study examples. So this gentleman, unfortunately, he had his hand squashed in a die cutter while he was at work. And he had a washout and a debridement where the surgeon tried to figure out what was going on. And he had a pretty much full house extensor tendon injuries that all needed to be repaired. I first saw him 10 days after his surgery, and he had quite significant pain, 5 out of 10 pain. A little bit concerning for me was that he had pins and needles and in his middle finger, although I knew the mechanism of injury was on the back of his hand, so it must have been the swelling that was causing some carpal tunnel syndrome symptoms. So I needed to keep an eye on that because his swelling was significant. So more than 50 centimeters when I wrapped that. And just to give you context, I measured mine and mine was just under 40 centimeters. So it was really, really big swollen hand. I didn't assess his range of motion. I didn't note that, but I did note that all of his extensors were intact, including his EPL. And I did notice that his middle finger and his ring finger were looking very strange. They were moving in opposite directions, and you'll see that in a few slides' time. So how am I going to prioritize this? I know he's got fractures. We're looking at quite a nasty looking ulnar fracture. There's a 1/5 of metacarpal fracture there, but that's pretty stable. Okay, and I know that he's got an extensor tendon full house. So I need to protect that ulnar fracture and I need to protect the extensor tendon. So I'm going to treat as a full house extensor tendon repair because that's a forearm splint and I know I'm going to include the wrist in that. There was a large crush component around the thumb and the carpal tunnel, as I mentioned. So this also is something that I'm going to prioritize treating. So I made him a splint that looks similar to the one there, but it had to include his thumb because his EPL, his extensor pollicis longus, was also repaired. But the splint allowed the tips of his fingers, so his PIP and his DIP joints to bend. And then I started getting him to lift his thumb up off the splint and do a jog of IP joint movement. I used some Coflex on his fingers and just a pinch application. We did a lot of elevation, safe active movement with the extensor tendon early active protocol. I used some K-tape to help drain the swelling away. K-tape works really nicely with swelling because it takes swelling from a high concentration to a low concentration. So you almost just do a line of tape with no stretch, and it starts where the swelling is and it must end further away. I instructed him to do big shoulder elbow movements, remembering that you've got nice large lymph nodes where your swelling needs to drain to under your armpit. And also just to walk around, gentle exercises, because breathing itself helps to stimulate the lymphatic system. I couldn't do much in terms of his wounds. His stitches were still there. And then his ring and middle finger, I buddied together with zinc oxide tape to try and reduce the angulation. So I only took a picture and video of him at 4 weeks post-op. I just want you to have a really good look before I say any more. This is him at 4 weeks. And you can really, really notice the extent of the swelling. And also you notice there's not much movement happening. So what do we know about swelling edema that sticks around is that it slowly becomes harder and harder in its consistency. It thickens and it becomes more difficult to remove. The other thing I want to show you, and I'm just going to show you the video again, because I want you to just note where the scar is. So that scar along the wrist is just going to block any draining of that swelling down into the wrist. So it was just sitting here behind his metacarpals. And then on the palmar side, because your skin is so thick on the palm, your body also struggles to get rid of swelling in the palmar area. Usually what I would do is I'd use K-tape through the web spaces and then allow it to drain on the dorsum of your hand where your skin is so much more elastic and forgiving. But in his case, I struggled because of that scar here, that scar that was deep down to the bone, blocking all means of this lymphatic system working through there. So I was still worried about the median nerve getting squashed because it was really swollen around the thumb and wrist area. But now what am I going to prioritize? I need to get MCP joint flexion back because we know that a fist is function. And I need to get thumb opposition back because that's also function. So what did I do? I started to try and make that scar tissue as pliable as possible. So I spent time touching, feeling, trying to get the scar movable. I then did a much gentler massage. So his swelling was a little bit like pitting. So I knew it was really, really thick. And I needed to do gentle, almost stroking movements to try and move that gel-like swelling down the hand, but away. And you can see the blue arrow that I put there to the radial side of the hand and around that scar and out. So I also used K-tape to try and mobilize that edema. So I taped around exactly that pathway. And then I changed his splint to a volar wrist splint. So anybody will do this, but when our brains are incredibly clever, but when our joints are stiff, and you will have seen your patients do this, and you ask them to bend their fingers, but their fingers are stiff, they're going to bend their wrist. It's almost as though the brain is trying to compensate and help. And so patients will do this. So what you need to do is you need to help them isolate the joint that you need to work on. So immediately I made a volar splint to block the wrist so that it can't help with flexion, and try and isolate the MCP joints to flex and try and allow him to do active movements to get more flexion, and also active movements to try and help drain the swelling out of the hand. Again, I just kept budding the ring finger to middle finger because they were doing strange things. I also used K-tape to lift the scar with a little bit of a stretch. Lots of active finger exercises. He was doing his tendon glides. He was also sitting with his PRP joints in slightly flexed positions. This is what happens when swelling sits in the joint. So we started doing a bit of passive extension there. Thumb opposition, always trying to get active movement into opposition to try and budge that swelling that was sitting there. Ongoing support at the wrist, because remember he had the ulnar fracture, and I measured him up for a pressure garment glove because we really had some stubborn swelling in this hand. So this is what he looked like after that session. The K-tape that you can see going through the web spaces to try and drain the swelling away from the volar side of the metacarpals, so that we have space to bend the metacarpals. But you can see how little MCP joint flexion he has. But we're only at week 4, so we can't start passive finger flexion yet. It's all about active at this stage. But then as the tendon allowed, we progressed the treatment. I did have to add a extension splint for him because I wanted to stretch him into extension, his fingers and his MCP joints. And I just remolded that every time I saw him. I started seeing him a bit more frequently. Isolated tendon glide. So I wanted FDP in isolation to FDS movements, lots of scar massage, lots of manual edema massage. And then early at 5 weeks, I started with passive MCP joint flexion of individual fingers. Again, still prioritizing thumb opposition and FPL pull through the tip of the thumb. I practiced grasping objects with him. I wanted to reconnect this gentleman's hand and his brain. He wasn't able to use his hand at all, so I was trying to find objects that he could pick up independently. And then at 7 weeks, I added straps to pull the MCP joints into flexion. I couldn't wait anymore. It was just too stiff, and I got the go-ahead from his hand surgeon. I also started applying gentle resistance. So that's how, with resistance, how we unstick the tendons. I started using suction tools. I have a snake bite kit, and I use that to lift the scar tissue as much as possible. Resistance to help with thumb opposition using an elastic band, and then started with therapy a little bit later in varying resistances. And throughout, I used a neoprene wrist support once he wasn't really in splints anymore to protect his wrist. And then I got the doctor to take a video for me. This was him 7 months down the line. So he did really well, and he was back at work. So we were very happy about him. This next case, he also got crushed at work, crushed on the thumb side and on the radial side of his wrist. He had an extensor carpi radialis longus, an extensor carpi radialis brevis tendon repair. So those are the wrist extensors on the radial side of the wrist. And you can see that his first metacarpal was pretty badly damaged, and he had some extensive plating done there. He was crushed by a large paper roller. They make cardboard food containers where he works. Unfortunately, this gentleman's full thumb was immobilized, and he was in a cast all the way to his fingertips, and he was basically immobilized in the position that you see. So this was incorrect. His fingers should not have been immobilized at all. So his cast should have been below his distal palmar crease to allow him to move his fingers from the beginning. And his thumb IP joint did not need to be immobilized either. So we would have only needed to keep the wrist flexion for the extensor tendon repair and support the base of the thumb for the reduced fracture. So this was him at 5 weeks post-op when I first saw him. Okay, so I put together a problem list. He was a heavy smoker. You can see that patch of skin wasn't really healing so nicely, and it was already 5 weeks old. Again, there was a crush component here. So lots and lots of swelling, lots and lots of thick scar tissue. Unfortunately, his hand was completely flattened by the cast that he was put in. And immobilized incorrectly, as we've already discussed. He had absolutely no thumb IP joint movement or opposition. That thumb wasn't even able to move side to side or up and down. His finger extensors were stuck in that nasty scar on the back of his hand. And this has caused some extrinsic tightness in the extensors. So those extensors now cannot stretch to allow the fingers to flex. Absolutely no MCP joint movement at all. And he was in a lot of pain. He had 5 out of 10 sharp shooting pain down the thumb, and pain with any movement because of the skin tensioning. He also had nerve signs. So he had a positive tonal at the carpal tunnel. So his median nerve was very unhappy, but he also had a very unhappy sensory branch of the radial nerve. And he was getting sharp tingles along the back of the radial side of the wrist into the top of the index finger and into the back of the thumb. So we did a quick assessment. We saw that the MCP joint flexion was only about 30 degrees and about 30 degrees of PRP joint flexion. And there was absolutely no thumb opposition. He couldn't do it. The IP joint at the tip of his thumb moved about 4 degrees. And so his tips of his fingers were 9 centimeters away from his distal palmar crease. But he's now already 5 weeks post-surgery. So I'm not going to continue with any protective splinting regime for his extensor tendons. I'm just going to get him going. As I always do, I'm going to prioritize reducing his swelling because that will help reduce the pain. So first port of call is always going to be swelling, and then it's going to be MCP joint flexion and thumb opposition. And you're going to see this recurrent theme. So what did I do? I made his hand a little bit warm with a heat bag, and I did lots of scar massage. And I felt and I could feel what was happening there. Scar tissue was incredibly stuck down. His swelling was incredibly thick by this stage. I started him with gentle passive finger flexion stretches, which I taught him how to do, and also started to stretch his thumb into opposition. I applied some K-tape to try and help loosen the skin tissue a little bit. I got him to pick up a sponge, again, to try and get some function going, get him to use the hand a little bit and connect the hand and the brain. I made him a volar wrist splint, again, so that he can isolate MCP joint flexion, but I started with flexion straps immediately. And again, to focus on MCP joint flexion, thumb opposition, and I started seeing him twice a week because we had a lot of work to do. So this is him at his second session. So you can see I put a lot of tape on him. I've used tape to lift the scar tissue. Not much MCP joint flexion when he's flexing his fingers. That's showing us extrinsic tightness. And the thumb is still very tight, but he can get opposition to his index finger. So we are gaining. This is what his flexion straps look like, and he had a thumb opposition strap as well. And this is him 4 sessions later. So some nice progress. I'm going to show you that again. Note that when he bends his fingers, his MCP joints extend a little bit. Again, that's showing us that he has extrinsic tightness and that his extensor tendons are stuck in the scar as well, so adhesions. Okay, so that was just showing you that the scar is moving with it, so the scar is stuck to the tendons. And this was his thumb. Okay, so there's no way he can grab a cup of coffee just yet. So I did a little bit of skin scraping here, which I like to explain to my patients, just like massage, but that little nice blunt rounded edge is doing it in a very small surface area for me. I'm just trying to make the skin as pliable and movable as possible so that when your patient is moving, there's no tension in the skin. And then that picture shows what he looked like when I finished lifting his scars all around. And then I like to try and help pull the skin towards the nail so that you are pulling the skin and giving the joints space to bend. And I did it to all his fingers as well, as you can see in the picture on the right. These taping techniques I learned from Alison Taylor, and she has a lot of videos on Facebook and on YouTube. She is the skin and taping guru. And this is just called a fan cut technique, also to try and help reduce the swelling and puffiness on the volar side of his MCP joints. I always like to explain to my patients that if you can see swelling on the hand, then you know that all the joint spaces are completely flooded. And if the joint spaces are full of swelling, we cannot move those joints through their full range. And then that's what's blocking the movement. So I try to get rid of the swelling as a priority always. And then I spent a lot of hours with his arm on a beanbag, stretching those MCP joints down into flexion. And once I got the MCP joints down, then I added the PIP joints. And once I got the PIP joints down, I added the DIP. So that is how I prioritize the stretching. Always MCP joints first, then the PIP joints. Even if your patient doesn't get any DIP joint flexion, but they can touch their palm bending MCPs and PIPs, that is still functional. And then again, I was getting him to pick up things and squeeze things and move things throughout the sessions. And now here we are, 8 weeks post-surgery. So now he's 6 sessions in. After this, he graduated to once a week sessions, and he was using his hand for light function. So he still had some extrinsic tightness on the back when he made a full fist, but his pain was right down and he was able to use his hand functionally. And you can see the ease and the speed with which he's doing this activity. And getting him to do some resistance. So I find that the putty or any form of resistance, the sponge or squeezing out or rolled up towel or anything helps to marry what we've gained passively with what the patient wants to gain actively. So you want to get the same passive and active movement, if that makes sense. And then this is 7 sessions in. Okay, so he started doing really nicely, and we could start with a bit more work hardening. He used tools and he was really weak though. But you can imagine after 9 weeks of not really being able to use your hand, how weak your muscles get and how much you lose your dexterity. So he was feeling very clumsy. But look at him go. So he did really nicely. Okay, moving on to this gentleman who was a complete replant, basically. He was hanging on by a corner, the medial corner of his elbow. His median nerve was amazingly intact, as was his ulnar nerve, but he had a dense neuropraxia, so it was very compressed. His radial nerve was repaired, and he had multiple fractures. I mean, you couldn't really see with all the pieces, and the elbow was dislocated. His arm got pulled by his jacket sleeve into a recycling crusher machine. And as you can see, he had multiple surgeries. So first of all, vascular repair and skeletal repair, as we spoke about right at the beginning, how the surgeon prioritizes. And then, unfortunately, patient had sepsis. They had lots of debridements, X-fix adjustments, more debridements. Eventually, he managed to have a skin graft, and then his VAC was removed. So what did I need to do? Okay, so there's the X-fix. So the skeleton is getting sorted out. The skin closure, he's going to need a graft. The VAC dressing is on there. But now he's got radial nerve palsy. So we need to position the wrist with a splint. And we need to maintain passive wrist extension and passive finger extension and flexion because it was really weak. And didn't have the ulnar nerve because that was densely crushed as well. And passive thumb extension and end range flexion. So teaching him how to do all of these exercises and do them regularly to keep his joints supple and keep the soft tissue length. So that's just another look at what he looked like after the skin graft. And there's the example of the splint that I made him. We had to work around the X-fix pins a little bit. And then eventually his elbow was fused. So it was all about wound healing, pin site management, maintaining the passive range of motion again, preventing the wrist drop, and trying to promote some functional use of the hand while he's in all of this. And this is just showing you how I just made a small adjustment to help his function. So he has no finger extension and he has no thumb extension. But he still has this massive X-fix on. So we are a little bit limited with what we can do with the splinting. So I add a little strap to help stretch out his thumb, just to give him some function. I haven't seen him yet. I'm seeing him on Thursday, but his X-fix has now been removed. So now we can start doing the more dynamic finger extension splints for function. But that's all I had on him so far. And then we had another complete replant. He was also caught in a recycling crusher machine. He was first seen at Groote Hospital, so I'm not entirely sure of the first date, but when the hand surgeon that I work with came across him and he found out he was an injury on duty, he had the patient transferred across to a private hospital where I could see him daily and start getting him moving. So he had also multiple surgeries. So initially, we wanted to keep his wrist in neutral. He had the radial nerve repaired and he had wrist drop. And we wanted to position his MCP joints in flexion because we knew that, or in a posi position, because we knew that he would start clawing because he had an ulnar nerve lesion. He had a big bulky graft done to his forearm and he had very poor blood supply because of the terrible crush injury. And we attempted to help with swelling with compression, but he just didn't tolerate it. So we couldn't put any form of compression on his arm or forearm. He went on to have the ulnar bone orifed and the ulnar nerve repaired. And then despite all our best efforts in trying to keep the MCP joints in flexion, he didn't tolerate the dorsal blocking splint very well. So he still developed this intrinsic minus position with his MCP joints in extension or hyperextension and the fingers flexed. And we continue to try and soften that scar tissue. That is a complete circumferential scar. So again, the drainage of the edema was very tricky. So he ended up having a flexor tenolysis and to bring his MCP joints down into more flexion so that we could start working on function. And so we tried to maintain this position with the splint that's shown in the picture to try and maintain the gains from surgery. So pulling that thumb into opposition and pulling his MCP joints into flexion. 8 months down the line, and his median nerve started to wake up, and he started to show some thenar muscle recovery. So now we're going to try and maximize that lateral pinch, the thumb to the index finger. And so we got him picking up a tiny little jiggle ball. This is him in therapy, and he got it right. And then he sent us a video. He is so compliant. He's even doing his exercise in the shebeen. You can see the crate of beers. So priorities, we needed to help with wrist extension. So he started getting some active wrist extension back. So we started strengthening it with a yellow TheraBand. His thumb opposition was coming back. So we started strengthening it with a little elastic band around the thumb. And we kept on trying to maintain passive MCP joint flexion with that static progressive splinting that you saw. And now his median nerve is starting to wake up even more. He's now 8 weeks post MCP joint release and tenolysis, 8 months post that ulnar nerve graft, and 9 months post median nerve repair. And he's almost able to touch the tip of his index finger now, whereas before it was just a lateral pinch. And then the picture on the right is showing how much active MCP joint flexion he has. So he's doing really, really well. And that's how much passive MCP joint flexion he has in the splint. Okay, so those are the cases. These hands are really, really complex and hard to get progress. And I just wanted to mention that if you're seeing a patient regularly and you're not getting any improvement, you really do need to reach out to someone who's a bit more experienced, who can help or mentor you, or refer to a hand specialist. The further down the line these stiff hands get, the more difficult they are to rehab. And patients actually tend to forget how to use certain muscles and grasp. So they forget how to flex MCP joints. They forget that intrinsic activation, and it's all about the long flexors or whatever. And then they actually can't grasp like it. So patients may not regain function. So it is really important to be on top of it. And what do you do if these injuries do present late? Well, obviously, the best case scenario is to start treating your patient post-operatively, and then you can preempt a lot of the complications as much as possible. But what do you do if your patient is coming 6 weeks or 6 months after the surgery? Don't panic. See what you can see. So this is a picture that I got from my colleague Henry, who works at the Grooteskier Hand Clinic. And this patient had capsular, so joint tightness, and extrinsic tightness through his flexors this time. So the flexors were really tight and pulling the wrist into flexion. And what I would suggest is think soft tissue, low load, prolonged stretch. So it's no good pushing as hard as you can and hurting. You need to get to the point of the stretch and hold that. And actually, that's something I probably should have mentioned from the very beginning, that these patients with these really, really swollen hands, if you're just forcing them as hard as you can, you're just constantly triggering an inflammatory response, and their hand's going to be painful all of the time. And then you're not going to win, because that swelling will not remain if you will keep making the hand swollen. So low load, prolonged stretch is key. Start with the wrist. Aim to get the wrist in at least neutral, if you can, 30 degrees of wrist extension. And you use the Sims technique, which is casting to mobilize stiffness, described by Judy Colditz. So in your session, you're going to heat up the arm, you're going to massage it, you're going to do passive stretches. And then once you think you've got optimum stretch for the day, that's when you apply your plaster of Paris with lots of padding. And then you repeat seeing these patients every 5 to 7 days, hopefully progressing the amount of wrist extension you see. Flowers and Listeo recommend 6 days. So anything from 5 to 7 days in those casts before you change them. Then once you've got the wrist out, then you're going to attempt to get the fingers down into flexion. I've said there in the corner, no nerve damage. Just wanting you to be aware that if there is nerve damage, you can still stretch them out, but then you need to maintain, because there is a muscle imbalance, you need to maintain that position. So maybe nighttime splinting would work really well. And that's another way to bring your fingers down into flexion once you've got your wrist in extension. Okay, so always take your patient's context and occupations into account. Be careful to only issue the very necessary instructions. So for that replant patient, all he had to do was wear his splint and pick up that jiggle ball. Too much information and too many instructions are just overwhelming for some patients. Obviously, I come from a private practice and I have access to amazing thermoplastic materials, but plaster of Paris is an amazing tool to use. If you've got access to it, you can make it work. I make those little jiggle balls out of scraps of materials and the rings and some assistive devices, and I'm going to show you a few now. And then just to say, really involve your patient in your planning and what you're thinking, because they're surprisingly resourceful and creative. The picture on the left, a patient told me she couldn't press the buttons on her remote control, and could I make her something big with a pointy edge? So she told me what to do, and that's just scrap material with a nice big grip and a pointy edge, so she could press the buttons on her remote control. And then similar, just a scrap of material, of thermoplastic material, folded over the top of the key for a more comfortable and larger surface area to grasp. That universal cuff on the left, I actually used pool noodle. It's a nice cheap material, nice big grip, and it worked really nicely. And then I made that button hook with a bit of scrap wire and scrap material, the button aid with the zip aid at the bottom. We used Plasterzote or built-up grip quite a lot. And if you don't have access to that, Coflex is quite nice and cheap. It's a compressive bandage, but it sticks to itself. So I often will wrap that around the patient's pen or toothbrush or whatever tool it is they're trying to pick up, so that they can grasp it, and then you can slowly unwind as they get more finger flexion. Just another example using the pool noodle. This is a post-box type splint, but this patient, I don't often see neuro patients, and this patient had spasm, so I wanted something really soft and forgiving. So I used that pool noodle again. And then this is how I use the jiggle ball. So scrap material that I've just made into a sort of a ball. And the ring, it's really nice for regaining dexterity, and you give it to your patients to take home and play with. Okay, so in conclusion, wherever possible, prioritize getting rid of the swelling first, because if you do that, your pain levels will drop. Always focus on getting your MCP joints into flexion, then your PRPs, then your DRPs, and also thumb opposition. Like I said, even if that thumb is super stiff, if it's in the right position, it can be used as a post against which the fingers can grasp items. Okay, so these were the pre-questions that you guys sent in. So I'm going to go through those quickly, and then I'm sure there's time for, oh, gosh, we are quite late. Sorry. Let me go through these pre-questions quickly, and then if anyone wants to stay on, then they're welcome to. How do I prevent a stiff hand without tearing tendons? You adhere to the tendon healing timeframes, and also you can stretch again by detensioning the tendon, depending on which. And starting early active protocols, so safe movements, early as possible, I would recommend. What causes CRPS to develop, and how do I treat it? Okay, so I'm not a pain expert by any means, but a CRPS is a pain syndrome, and it's very much a centralized issue. So what I mean by that is it's in the brain, and it's basically how pain is perceived in the area of the brain that represents the hand. And in my experience, even very innocuous or small injuries, something as simple as a paper cut, can cause a CRPS or allodynia, which is a heightened pain response initially. And I think that it all depends on what's happening in the patient's life at the time. I think that if a patient is experiencing heightened stress in their life, and then they injure themselves, it's just almost too much to bear. So they've got this exaggerated pain response because life is so stressful at that time. And also CRPS can be linked to how long the pain has been experienced for. So remember that if you've had pain for more than 3 months, then it definitely has become a centralized problem, and you need to be treating the brain as well. But in terms of how to avoid CRPS, obviously this is my opinion, is trying to see the injury early, trying to reduce swelling early, because remember, your swelling is squashing all those little nerve endings. And I believe that swelling and pain are closely linked. And then look for red flags, discuss. As therapists, we're lucky. We have time with our patients, and they can tell us about their issues, and look for the red flags. Refer them to counseling if you feel like it's necessary. And then think skin, think detensioning skin. And K-tape is such a beautiful product to help us with that. In cases where patients experience a lot of pain, how can we best address the pain management while still preventing stiffness? And I think we kind of covered that. Guidelines for hands. This is an interesting. Do you use electrical stimulation for denervated muscles? I don't. I looked extensively into it, but even using TENS machines and things doesn't seem to keep the motor end plates of the muscles alive. And the research that I found showed that it actually wasn't worthwhile. But I do know some colleagues who use it, and they actually send their TENS machines home with the patients to try and use them as frequently as possible. So I think there's a need for more research here. I want it to be something that is usable, but I don't have it. I just didn't feel it was worthwhile. As the research said, it wasn't helpful, but I do like to believe it is helpful. How to prioritize what to treat first in complex hand injuries. We covered that. Swelling, MCP joint flexion, thumb opposition. New advanced techniques. Not sure if I'm the the right person to answer that. I've been using age-old things, except that the taping is relatively new. So that's Alison Taylor. So go look for her. Yeah, that's it. I don't have anything else to say. So thank you very much for listening. And I'm very happy to, if you guys want to stay on and ask any more questions.
Trish, there was some interesting questions in the chat. I think there was, so I'm going to just throw a couple of them at you in the next maybe 10 minutes, and then if there's leftovers, you can maybe take a look. But there was a little bit of a conversation around, you know, therapists who are working in government hospitals and don't have good communication with their surgeons, and then struggling with tendon rupturing. There was a bit of a discussion, a dialogue around it, but I wonder if you have just any advice, like is it better to immobilize longer when you're not sure about the quality of the repair, or what would you do?
One.
Yeah.
So what they do at Groote Hospital is the first week they're in the back slab and fully bandaged. And then at the wound check, they actually cut out the palm so the patient can move. And again, they just need to know move, but cannot use. And this is where the problem comes, is with choosing just the right amount of information to give your patient to try and get them to be adherent in the treatment. I would always advocate early active motion, yeah, because it often leads to more surgery being required. So either it ruptures, you need more surgery, or you need a tenolysis. Yeah, I would, yeah. My answer would be early active is always best, and
And that kind of comes to another discussion that was in the chat, was just around one participant said that their hospital has a strict immobilization policy for 4 to 6 weeks. And there was a comment around early active mobilization being better. So yeah, maybe do you want to expand a little bit about early active mobilization? Maybe try convince her to change the hospital policy.
Sure. Yeah, I mean, there is a lot of literature out there that does prove that early active mobilization protocols are the best. So perhaps that's a way to approach the surgeons, whoever's made the immobilization protocol. There is a lot of evidence out there, and yeah, you're always going to get complications if you immobilize. You're going to have swelling, you're going to have sticky scar tissue, and the repaired tendons are just going to be stuck in the scar tissue. So you're going to really, really struggle. So at least allowing some movement early on, you help prevent some complications.
Cool, thank you so much. There was a question just around in the first 2 cases you mentioned like soft tissue injury being treated first. Is this because the fractures had healed or been stabilized, or is it just good practice to start with the soft tissue? Yeah, maybe just comment on that.
Yeah, so yes, if the fractures have got plates on them or wires through them, then we can often start moving quite early. Whereas if and it again, it depends on how happy a surgeon is, because sometimes we would then prioritize the fracture over the tendon healing. If the tendon healing, I mean, if the tendon repair was really strong, then it means that we could err towards mobilizing early. It's very variable. There's no hard and fast rule here, unfortunately. It's very case dependent. But from the beginning cases, if I can recall, if this fracture is stable, then you don't really need to worry about them so much. So the guy with the complete extensor repairs, he had a stable fracture, but also the splint was going across the forearm. So his wrist was still in a splint and immobilized. So it kind of covered both.
Do you choose taping over silicone gel to soften scars and adhesions?
So yes, especially with my workman's comp cases, silicone pieces get lost so easily. And I really find that this stretch on a scar helps to lift and flatten it. I think scars respond to occlusion. I don't necessarily believe it needs to be silicone. Yeah, controversial, but yes, I do. I use K-tape. It's cheaper.
And then there was just a question around radial nerve repairs. What type of splint do you use in the first 2 weeks post-op? And I think it was specifically if repaired at a mid-upper arm level, do you also immobilize the elbow? You following that one?
Yeah, no, I don't. Mid-upper arm level. No, I don't immobilize the elbow. I initially just help with wrist. And then as the patient progresses, I mean, if it's a repair, then you know it's going to take a while. You can go straight into finger extension splint, dynamic finger extension splint. I prefer patients to have a little bit of time just with wrist extension. And then I play around with just a thumb extension strap, see how they're doing, and then potentially evolve. Yeah, I don't often do it straight away.
Well, I think that covered most of the conversation in the chat. Yeah, so I think maybe let's wrap it up there. Thank you everybody for joining. You'll receive a link to the Zoom recording by the end of the week, and later down the line, the webinar will be made available on YouTube, so please share it with people who may have missed it this evening. Our next webinar is on the 7th of October, so look out for that sign up, and it's going to be on de Quervain's tendinosynovitis. And then here's a QR code. If you want to join our mailing list, then you'll get the emails for the next webinar and some news from us every month. And we're very excited. We are over 700 followers on Instagram, so please keep engaging with us on our social media platforms. Yeah, and we hope to see you again in the next webinar. Yeah, so thanks everybody and have a good evening. Yeah, and a special thanks to Trish.
Thanks for having me.